I'm part of, I'm a consultant psychiatrist. I'm a clinical director of a mental health service in Ireland, in a rural part of Ireland. Prior to that, I've worked in inner city areas in Birmingham and in Bradford in Yorkshire. I've been a psychiatrist for about 30 years, and I've worked in the UK, I've worked in Africa, I've done overseas work in various parts of the world. And my presentation to you today, I guess, emerges from that kind of experience. I'm part of a group of psychiatrists who started meeting about 15 years ago because we were kind of unhappy with the way our profession was going, and particularly unhappy about the close links about 15 years ago being established between the pharmaceutical industry and psychiatry. We felt that there was too much penetration of pharma into the thinking of psychiatry. And a group of us started to meet in Bradford, and that's eventually become the Critical Psychiatry Network. And we now have about 120 psychiatrists, mainly from the UK, but from the States, from Australia, and from other parts of the world as well, linked in. It's mainly an internet discussion group, but part of my presentation today is about critical psychiatry, so I'll explain what that's about. But I'd make the point that I don't speak on behalf of the network. The presentation I'm giving you today is pretty much my own take on things. I don't seem to have my slides, which is unfortunate because a lot of the presentation is based on the slides, but given the pressures of time, I think I'm just going to crack on. What I'm trying to do at the moment is to look at the notion of critical thinking in mental health, and critical psychiatry in particular, and to try and take that from being something of a negative, something that criticizes, something that's seen to attack profession, etc., and turn it into a positive, to take critical reflection on our assumptions, our values, our practices, not as a negative phenomenon, but something that is positive, because it opens up spaces and it opens up different ways of looking at things. In my talk, the first slide would have been of Socrates back from 2,500 years ago, and the tradition of philosophy itself and its birth in Greece was about critical thinking. Socrates, as a philosopher and as an educator, refused to simply go to his students and give them theories and facts. His whole approach was about dialogue and about doubt and about questioning, and constantly questioning. For Socrates, true wisdom involved an appreciation of the limitations of one's knowledge and the ability to critique one's assumptions. The next slide is of Paulo Freire, the great Brazilian educationalist. And Freire was critical in Brazil of a great deal of the educational practice around the world. And he spoke about what we have at the moment, he said, is a banking approach to education, where the educator, the teacher, tries to fill the student with facts about the world and not encourage critical thinking. In his book, Pedagogy of the Oppressed, Freire talked instead about the development of what he called a critical pedagogy, an approach to education which saw the job of the teacher as nurturing critical thought on behalf of the student. And again, coming back to this notion of dialogue, that the idea of the teacher was not to be the person with all the facts imparting them to the student. The job of the teacher was to help and encourage the student to critically engage with the reality around them. The students, he said, no longer docile listeners, are now critical co-investigators in dialogue with the teacher. And that was what his central message of the critical pedagogy that he approached, that he developed. The next slide would have been a summary of what critical thinking has been about, from philosophy, from education, from psychology, etc. And it's concerned with the idea that the current status quo, the current common sense in which we live and grow, is not fixed, but is something that can be questioned, something that can be challenged, something that we can get beyond. So critical thinking is about questioning our current common sense. And that can be difficult because it is our common sense. It is the kind of common sense in which we live in the world, and we don't often question it. The assumptions, the values that we use to get by in our daily life. Secondly, in the tradition of critical thought, is this notion of dialogue. That the goal of critical thinking is to encourage dialogue, encourage spaces where real dialogue can take place. And that's not always simple, because economic forces, political forces, etc., often create the circumstances whereby real dialogue doesn't take place at all. And thirdly, those who argue for critical thinking do so with the ultimate goal of promoting genuine citizenship. The citizen, from a critical thinking point of view, is not just a consumer, someone who's happy to be defined by someone else, someone who is happy to be accounted for in the knowledge systems developed by someone else. The citizenship that we are talking about emerging from critical thought is an active citizenship, where the person is actively involved in defining the knowledge systems in which they are engaged, and etc. I want now, and in the slide that I would have had here, to present to you an analysis of what I think is our current common sense in mental health work. And this is what myself and colleagues have called the technological paradigm. Often we talk about the medical model dominating in mental health circles. I believe it goes deeper than that. It's not just about the medical model. It's a deeper way of thinking about mental health problems, thinking about them as technical challenges to be fixed in one way or another. And there are three fundamental assumptions within that paradigm. First of all is the idea that the problems we address in mental health have to do ultimately with faulty mechanisms or processes in the individual. These are most often understood as being biological in nature, but there are technological versions of psychology that provide descriptions of faulty cognitive or emotional processing, for example. So that's the first assumption. Secondly is the assumption of what kind of knowledge we're going to have about those processes and mechanisms, and the idea that we can model those problems in what I would call causal terms. For example, in medicine, we model something like malaria in causal terms. It's caused by a certain organism that interacts with the body in a certain way that then causes certain symptoms, and our treatments can engage with those. And you can actually spell that out in algorithms and diagrams, etc. It's a causal model of malaria. And that doesn't depend on the context in which it occurs. You can move that model around the world. So malaria is the same disease in Brazil or in Colombia or in Africa or in this country. So it's not dependent on the context in which it occurs. So the goal within a technological way of thinking about mental health is to produce causal models of depression, anxiety, schizophrenia, etc. And contextual factors, the social environment, the relationships, etc., are kind of in the background. What you're really looking at is producing, as I say, a kind of causal model. So that's the second assumption. And thirdly, the assumption about how we intervene, what our treatments are about, and they're essentially technical interventions in these faulty processes that we identify. So our treatments are typically understood in terms of discrete interventions, and the whole process of evidence-based medicine is actually about really, finding out what specific technical ingredients of our treatments fix the process, the faulty process of one sort or another. So in the technological paradigm, our engagements with people are not about relationships, not about meanings, values, and all of those kind of things. They're actually about fixing the faulty processes either in the brain or the mind of the patient. And those, I would put to you, are the three fundamental assumptions that guide our technological thinking about mental health problems. They guide, they're pervasive in terms of our professional training. They're pervasive in terms of how we think about developing services. They're pervasive in our media discussions about mental health and the problems that come up. And in that framework, expertise is seen as technical expertise, that you go away and you train as a professional in the model, in the knowledge, in the interventions, and you become the expert, the person to whom your patients and their families come to for expert knowledge about the faulty mechanisms and processes, etc. And your job is to come up with the treatments that fix those kind of problems. Importantly, within the technological paradigm, issues to do with relationships, issues to do with values, issues to do with meanings are not forgotten. They're not ignored, but they're very much secondary to the primary task of mental health, which is, as I say, technological. And we see that, for example, in psychiatry, in our journals. If you look at any of the major journals of psychiatry, you'll see about 90% of the articles are to do with diagnostic systems. They'll be to do with evidence-based treatment interventions or biological mechanisms underlying mental health problems, etc. Occasionally, you will have an editorial addressing the values of the profession or questions to do with meaning or relationships with people, etc., etc. But they're pretty much at the margins, at the edges. And in recent years, this way of thinking, in the past 20, 30 years, this way of thinking, I believe, has been funded to a great extent by the growth in the pharmaceutical industry, which has made billions, literally, from the idea that mental health problems can be modeled in this way and can be treated in this way and can be reacted to in this way. But I'm not going to get sidetracked on all of that today. Now, I believe that the recovery approach that has emerged from the consumer movement, from the service user movement around the world, the recovery approach is actually a revolutionary challenge to that technological paradigm. And as I say, the recovery movement grew out of users' experiences. What happened basically was that people who had been diagnosed with serious mental illness like schizophrenia or bipolar or whatever it is, but told basically that their lives were to be a patient and take medication and not to have too high expectations. A whole bunch of people who were given that message resisted it, got out of it, and developed a life for themselves and got away from psychiatry and the system, so to speak, and then wrote about that. And for some of them, yes, taking medication was important. For some of them, psychotherapy was important. But for many people, it had nothing to do with that. It actually had to do with embracing other things in their lives, whether it was spirituality, relationships, work, artistic creativity, etc. A whole series, what the recovery approach started to talk about, a whole series of pathways along which people could move on from being stuck. And some people said that actually their involvement with mental health services hadn't helped. And in fact, some people said that their involvement with mental health services and the way that mental health services had diagnosed their problems were actually harmful to them. And what the recovery approach pushed us towards is actually seeing things to do with relationships, things to do with meanings, things to do with values, actually as the center ground, rather than in the technological paradigm where the technical aspects of mental health are center and those non-technical aspects of mental health are marginal or secondary. What the recovery approach is actually telling us is that actually it's the other way around. The most important things are actually things to do with relationships, things to do with finding meanings, the importance of values, contexts in people's lives. It's not anti-drugs or diagnosis or professional involvement, but in the recovery framework, those aspects of mental health become the secondary aspects. Now, the recovery approach has been around for a while, and increasingly people are getting frustrated because this is what service users tell us around the world that they want. It's not being picked up. There's resistance, and that resistance can happen in different ways. And one of the ways in which I believe resistance to recovery is happening is that it's actually we're tending to technicalize the recovery approach, and in that process to neutralize it. So we're starting to think of training courses in recovery, of coming up with the central issues in recovery and then coming up with a model of recovery that can be taught, that can be treated, that can be, and losing in that process the very revolutionary potential of what this whole approach could do for us. What I wanted to move on to, and as I say, a lot of this was actually on the slides, was to talk then about the role of critical psychiatry in this. And as I say, critical psychiatry has gone through various historical moments. The current generation of critical psychiatrists, of which I would count myself a member at the moment, we have that technological paradigm in our sights, so to speak. Our whole effort, based on conceptual analysis, based on an examination of the empirical evidence around what works in mental health treatments, and through collaboration with service users, has been about challenging that technological paradigm to its core. And I believe that there are 5 dimensions to that process. One is, first of all, what I call an ontological challenge. That is, challenging the very notion that mental illness is an entity. Ontology has to do with questions of what actually exists. And critical psychiatry has challenged the idea, the reductionism that is involved in a lot of current thinking, the idea that you can reduce mental health problems down to simple ideas about dysfunction in brain systems, which is very dominant at present within academic psychiatry. We challenge that. We challenge that conceptually and by pointing to evidence against that. Secondly, there's what I would call an epistemological challenge. That is about what kind of knowledge, coming back again to that idea that the goal is to model mental health problems just as we would problems to do with the liver or the lungs or infectious diseases, etc. The idea is that we need different notion of what knowledge is about in mental health. We need much more to foreground what I would call qualitative ways of engaging with people so that meanings become center ground rather than reductive models that relate everything to the brain or a kind of mechanistic notion of the mind. Thirdly is an empirical dimension to critical psychiatry, and what I mean by that is looking at, systematically looking at how treatments actually work. And interestingly, 29 of us published a paper in the British Journal of Psychiatry the year before last where we looked at how mental health treatments work, because they do work. About 60-70% of people who take antidepressants feel better. About 70-80% of people who go for psychotherapy get something from that. People who have ECT, by and large, report that they feel better afterwards. We don't dispute that. But when you look at, for example, antidepressants and how they work, the evidence is fairly strong now that most of that benefit can be explained by what we call the placebo effect. I'm careful not to say all of the benefit because there's room for discussion, etc., but it's clear, and I don't think anyone would dispute this, that most of the benefit of antidepressants actually comes about through what we call the placebo effect. And what is the placebo effect? Well, it has to do with the relationship between the person prescribing and the person coming for help. It has to do with finding meanings and a way of framing one's problems. It has to do with the generation of hope and positive expectancy, etc. In other words, we can explain how antidepressants work. Largely, they're not fixing chemical imbalances in the brain. Largely, the process of benefits from psychopharmacology accrues actually through the relationship between the prescriber and the person that's coming for help. When you look at psychotherapies, there's a whole, people have looked at all of the therapies and analyzed them and compared them, etc. And again, what's clear is that psychotherapy works for people. But it doesn't seem to matter which particular version of psychotherapy you're actually using. What really matters in psychotherapy is the quality of the relationship between the therapist and the patient. Again, issues to do with the generation of hope, meaning, etc. You can be the highest trained psychoanalyst or cognitive behaviorist therapist, but if you don't actually click with that patient at that moment in that time, it ain't going to work. It doesn't actually matter too much what the technology is. In fact, it would seem, contrary to what we've trained ourselves in, the technology is the conduit for the relationship. The relationship is the really important stuff. We've traditionally seen it the other way around, that the relationship is the conduit to bring the technology to bear on the problems. In fact, the evidence would seem to be that it's the other way around. So there's an empirical dimension to our work in critical psychiatry. Fourthly is an ethical question, and I'm not going to dwell on that, but that does have to do with pharma and the funding of academic work and research and education within our field. Now, psychiatry is not the only branch of medicine that has been targeted by pharma and corrupted by it, I would argue. That's pervasive across medicine, but it is clear that psychiatry has been a particularly growth area for the pharmaceutical industry in the last 30 years. Lastly is what I call a political dimension to critical psychiatry. So I've outlined 5: ontological, epistemological, empirical, ethical, political. I'm putting names. I'm trying to frame an engagement with the current status quo that can open up opportunities to move on. And what I mean by a political dimension is the position of service users within our debates about mental health. If we continue to operate with the technological paradigm, the service user will always be the recipient of somebody else's expertise. It's built into the way we think about mental health if we continue to work in that way. So there's a political dimension. The technological paradigm in its essence puts the service user on a position of recipiency. They are the ones who are administered to by the professionals who are trained in the technology, the models, the treatments, etc. And yes, we can start to talk about service users helping us, etc., much as service users might help neurologists to, get people for research programs or to raise issues about funding for hospitals, etc. But service users aren't involved in defining the knowledge, as I would go back to in the critical thinking way of looking at things. If we're really talking about a dialogue, the technological paradigm, I would put to you, is an impediment to real dialogue taking place between professionals and service users. So my basic argument is that if we are genuine about recovery, and if we are really to see the revolutionary potential of the recovery approach taking seed and working. We have to engage in a critical analysis of the current common sense, the current status quo, so that we can create the conditions for real dialogue between service users and professionals. And until we do that, and if we don't do that, recovery will simply become another thing that we train ourselves in to do to patients of one sort or another. And the history of mental health has been a history of professionals doing things to people who are defined within their systems of knowledge on a lesser position. What I'll end with saying is that I come from Ireland, and we've just gone through an incredible cultural phenomenon, basically, where all of the institutions within our nation and our state have started to crumble. We've seen our church exposed as covering up sexual abuse of children by clerics on a massive scale. So the confidence that we had in bishops and cardinals, etc., is gone. I mean, I don't know if some of you might have connections in Ireland, but in my lifetime, this is a major change, you know, from growing up in the Ireland of the 1960s, where the church and the were sources of authority. That's gone in Ireland. Politicians have been exposed as, you know, one of our prime ministers in recent times, Charles Haughey, is seen now exposed to have been completely corrupt, taking payments from various property developers, etc., right up to recent times. Our banks have shown to have been completely corrupt, and across the board, and the medical profession as well, in a number of very serious scandals that have emerged. And people are starting to say, how do we allow this to happen? How do we go along as a people? You know, the Irish people are not deferential by nature. Do you know what I mean? We define ourselves in terms of an anti-imperialist struggle. You know, that's part of our very essence. How was it that we ended up in this kind of very deferential position and accepted sources of authority from people? Where were the critical thinkers? And they were there, but we marginalized them. We suppressed them. And we didn't nurture them. We didn't nurture the idea that critical engagement with the common sense, with the status quo, is not a negative thing for a society. It's actually essential for a society. And I look forward to a time when not just psychiatrists, not just doctors, but all professionals, anyone who through their training and through their knowledge systems has power in the lives of ordinary people, that any profession who has that through their training will have to be exposed to critical reflection upon the assumptions, the values, and the practices of that profession. And so I'm arguing with, my case is, if you like, that critical thinking and critical psychiatry is not a negative thing for psychiatry or for the mental health movement, but actually is a positive, necessary step in moving forward to a recovery-based system. Thank you very much.